Well, thank you very much for the invitation. Thank you, Peter Foss, as well. And well, just to let you know a little bit about my background, I'm working at the Technical University in Berlin, TUB, and I have a background as an architect. I graduated as an architect. That was a few years ago. And then I mastered in public health. So I'm quite safe because I can dodge the ball when it gets really tricky in architecture. I can say, well, I'm a public health researcher, and the other way around. So yes, it's basically I got into public health because there were a lot of unanswered questions when I had a phase where I was designing hospitals, and basically how to make decisions was kind of like the key issue, where to bring quality data to make the right decisions, especially in Venezuela, where I'm from, that there was like a lot of hospital development 10 years ago, roundabout. And well, there were very broad directives of how to design certain facilities, and everything was kind of like under question. So the questions kept on going, and I ended up in Berlin at the public health school, and that's where I did my second master. And I found some links to my core research in health promotion. So basically, the presentation which we'll have today is on walkability and how it's linked to health promotion. Well, basically there's two different cores in my research, and one is linked, as I said, to health promotion itself, and the other one, which is medical neighborhoods, is more towards all levels of care and disease prevention. So I was talking to maybe you're familiar with Elke, one of the PhD students here, that you've already stressed the difference between health promotion and disease prevention. So maybe I'll just address that really quickly as we go on with the presentation. So today, I think we have like more or less 50 minutes, an hour. We're going to talk about this first project, which is more linked to health promotion, Walkability for Health. And I wanted to give an overview, kind of like give a definition of what walkability is, and stress the difference with walkability for health and what it aims for. So I'm going to divide this presentation in two blocks. Block A, which is defining walkability, and looking at research gaps, which we have in three fields of studies, which is public health, urban planning, and architecture and urban design, which brings together concepts for walkability. And block B, where I will present really quickly an overview of this evaluation framework, which I designed with these three fields of studies to evaluate neighborhoods and how to assess factors and variables to improve conditions for pedestrian environments. And then the fourth, if we have time enough, I would like to show some exercises, results that we achieved with a group of students at TUB, where they used the framework and they assessed certain neighborhoods in Berlin. So right away in block A, well, let's start with walkability and its importance. So what is walkability? Basically, it's a concept. And as we maybe heard, walkability is the friendliness that a neighborhood has for pedestrians and for bikers. When we talk about walkability, we're talking already about active transportation, which is biking and walking, and means of transportation which are non-motorized. But it's also a measurement. It's a measurement because it looks at environmental factors of the built environment, which offer that friendliness, and it also looks at other factors which are not linked to the built environment, which are socioeconomic factors. Like, for example, if we have money enough to take public transportation or not, that's a socioeconomic factor. That puts pressure into taking the public transportation or not, or taking my bike or walking to a destination in my neighborhood. So these are two sets of factors which explain why we choose a mode of transportation or not. Now, walkability for health assesses that, but the difference is that it pursues other goals which are more broad in two realms, which is one, sustainability, which urban development is so much reaching for, and another one is looking for health outcomes, and especially how to attain positive health. I'll shortly explain what that is in detail. So in order to compose or to conceptualize what walkability for health is, I reviewed relevant literature for walkability from 3 different fields, as I said: public health, urban and architectural design, design in general for streetscaping and so on, and urban planning, and how these 3 fields would pursue health and sustainability. So there are 12 common goals in these 3 fields which are linked to walkability and what walkability offers. There's social and health goals, universal access for children, elder, and disabled, which are vulnerable groups in our societies, which if we design for vulnerable groups, we're designing for the whole population in general. We also pursue for neighborhood interaction and community cohesion. When we have high levels of walkability, we get to know our neighbors much better. We have better social interaction with them. And obviously physical activity, which is kind of like the goal which is more evident when we talk about walkability: walking rates, biking rates, and how to move around. 4 environmental goals are clear. One deals with pavement. Of course, when we have more pavement in our streets, we have more possibilities of having runoff, which is a way of polluting our streams, our rivers. We have, obviously there's no soil which is permeable, and then we have that kind of environmental issues. Less green translates into heat island effects in the city. And the most obvious and the most measurable one, which is energy consumption and pollution emissions. 5 economic goals also come together, and the most evident, I would say, is health cost. The more active we are, the better health outcomes we have. We pursue positive health. Transportation costs as well. Less fossil fuel translates into earning less expenditure in transportation. Walking tourism and heritage preservation is really interesting because, as we can see here in the lower right, there's, I would doubt a little bit about the nature of the study, but it was a survey on tourist agencies in Denmark, which assessed that for every certain amount of kilometers biked, there was an added value to the city. And that added value had to do with this word-to-word that Copenhagen is a very bikeable city and so on, and people would follow that and visit more of the city. There's another goal, which is, there's other 2, which are also related to economic goals. More local businesses surface, or at least they don't die out. When we have pedestrian scale businesses, as in these fronts, in that case it's Copenhagen and most of our cities in Europe, we have a better chance of having economic activity, employment, and so on. And the 12th goal, which deals with real estate. Now, this is a really tricky one because you might think of gentrification. Walkable neighborhoods tend to be more gentrified, or kind of like cool, and a bunch of hipsters going around with their bikes and so on and so on. But I like to look at it as an opportunity to design for those neighborhoods which are not walkable, which also would have the opportunity to improve their neighborhood environments for pursuing these other 11 goals. So it's kind of like looking at the other way around. So we have these 12 goals define what walkability is in general, but the question is, why aren't we achieving these goals? And I would say that the first grand general problem, or the first statement, would be that our healthcare systems have different targets to those strategies which our city developers or city development has. And you might say, well, this is stressing out very much 2 sets of goals. But we'll look at this, how, for example, a healthcare system works, and we could link a possibility of improving our cities and dealing with health promotion. So, I would like to give an overview. This is an overview of how the healthcare system works in Germany, and that's where I work, and that's where my research is focused and takes place. And I think there's an analogy here. It would work also to explain other healthcare systems, maybe the Swedish. Let's find about that. But basically, the targets which a healthcare system has deals with a pathogenic perspective, which deals with disease. We're not looking at how we could attain positive health, which is a different model. We're looking at how to be less ill, less sick. So what we have is a group of goals, which is aiming at specialized individual care. We take care of inpatients in hospitals, which deal with 4 levels of care, I would say. The 3 cares that you see there, and disease prevention, I would also link it to that group of levels of care which deal with disease. We also have practices which are staff-focused or patient-centered. It also deals with disease. We try to improve that in our healthcare systems. And when it's about the built environment and in the healthcare system, well, we put a lot into hospitals and ambulatory care and so on, which is basically the built environment for health that we know of. So that is, in general, very quickly, the overview of how the healthcare system looks like. It deals with disease. Differently, a salutogenic approach looks at, instead of decreasing disease, to how to attain positive health. And that's where this chart, what it tries to illustrate, is the positioning of this research, which is in walkability. And the approach is to stress that health promotion is something which is completely underlooked and unlinked to what levels of care are. Let me rephrase this. Normally, what we look at is that our healthcare systems are putting a lot of money, are putting a lot of resources into healthcare expenditure. 97% of our healthcare expenditure is going for clinical care or for that what I call a pathogenic model. Whilst 3% is for health promotion, bundled with disease prevention. So there's not a difference between health promotion and disease prevention. So this is one of the first aspects to stress out. So basically, the positioning of walkability for health lays on doing health promotion from the city perspective, from the city development, and making it discernible from disease prevention. So really quickly, before showing you the framework, I would like to talk about 3 different gaps or gaps in these 3 different fields or study fields, which are in public health, urban planning, and architecture or design. And the first gap that we see in public health is that we're tackling the problem from the wrong end. We see that we have 65% of our diseases that were in Europe and the European context deal with non-communicable diseases, diabetes, some cancers, and so on. And that is what basically is killing us. But the way that we're dealing with it is putting a lot of resources to the other end, which is to clinical care, instead of preventing that huge amount of diseases which are taking us to the hospitals in the first place. So what we have is that preventable diseases which deal with our health behavior is being attended with only 3% of the expenditure of healthcare that we have. So the other question in the public health realm is that research efforts are very narrow. When we talk about the impacts of the built environment on health, and we do research on that, what we think of first is the impact that the built environment has directly on our health. And we have good examples of that. We know that air pollution affects us, that it has an impact on our health, radiation. But what about the indirect influences on our health behavior? Well, that's a different way of looking at how the built environment affects our health. And when we talk about risk, about health behavior, we have 2 sets. We have risk-related behavior, which we all know that binge drinking, for example, affects our health, that smoking affects our health. But there's also another set of health-related behaviors which us architects and designers can deal and make a difference, which is reinforcing those health-promoting behaviors that protect our health. And basically, there's three where we designers have a huge influence on. And it's basically inviting people to do physical activity, engage in healthy diets, and engage in a more proactive social encounter, a positive social encounter. So maybe we've heard this many times, especially when we go to our doctors and we have recommendations on, well, you have to eat better, you have to engage in more and better physical activity and so on. But then when we go to our neighborhoods, our reality sometimes is a little bit different. We don't have spaces which could reinforce the idea of engaging into health-promoting behaviors. So breaking it down, what Walkability for Health pursues in public health is basically to look for the opportunity to support health-promoting behaviors with our built environment, looking at, first of all, health-promoting activities, doing research in the indirect influences on health behavior, and looking for opportunity and health-promoting behaviors by itself, as I just said. Social encounter, physical activity, and healthy eating. So let's look at some gaps that we have in urban planning. In urban planning, since the Athens Charter in 1943, we haven't really questioned much how we develop our cities. And to a certain extent, we still develop cities with that concept of zoning. We still don't have, at least from the healthcare perspective, a blend into how to develop the city with health purposes. And well, I brought like some examples there. These I think the three first slides, the three first pictures to the right, are these super hospitals developed in Denmark. And the second fact is that when we look at circulation and transportation in the city, we're looking at travel. So when we're looking at possibilities of developing cities and making them more walkable or more bikeable, we're only looking at travel, and we're missing the point of also planning for vulnerable groups or also underlooking possibilities for leisure and physical conditioning. So basically up to this point in walkability and how we have research in walkability, it's for travel purposes. And we're not really looking at other possibilities that could be realized at the neighborhood basis for leisure of physical conditioning, or they're basically overlooked. So that's how it breaks down to the second aim of the framework. How to assess mobility needs and requirements at neighborhood level. And the third point, which deals with design, deals basically with and something really key, which is how in architecture or in design in general we do research. I think that's also a big gap in attaining these 12 goals for sustainability and positive health, which is that we oftenly talk about research in architecture, and we miss a very essential point when we do research. That is that the measurable outcome, or the outcomes that we're trying to look at, the ways that we do architecture, are most likely into assessing what does the technical medical planning or the technical planning do in an architectural space, instead of assessing what the architectural space itself offers or changes in our health behavior or our health outcomes. Let me rephrase this. When we have in a hospital setting, for example, when we're evaluating how these settings, what they do, or what kind of, how they change our outcomes, or the outcomes that we're assessing, we're basically measuring what the technical planning or the technical equipment in that space is performing. Instead of looking, there's a huge difficulty there, to assess how that environmental space, or how that environment spatially, or that spatial quality is affecting our well-being or our wellness. The other point in architecture, which is also hindering, is that buildings are not, or architecture is not looking at a scale which is the pedestrian scale itself. We do fairly solve a spatial problem within buildings and maybe towards the entrance, but there is a scale which is at the street level, which rarely we cope with. Maybe in landscape architecture there is a link to how to do streetscaping for sure, but for example, I brought you this image of the O2 World Arena in Berlin. Well, those that know Berlin, this is right in the middle of two very lively neighborhoods between Friedrichshain and Kreuzberg. And we have this isolated building, which I call the unfriendly neighborhood, the unfriendly neighbor of the neighborhood, which has a huge amount of unprogrammed space, which definitely is far off to the purpose of dealing with walkable environments. So architecture and urban design is missing the opportunity to reinforce those health-promoting behaviors I was talking about, to reinforce the idea on public health, to design places to play, to engage in physical activity, places to eat for a healthy diet, to eat better, healthier, and places to meet, to reinforce that idea of social interaction, positive social interaction. So basically, walkability for health and design pursues that purpose, to build environment conditions for pedestrians that are linked to healthy destinations. So to break it down graphically, the three major gaps in public health, urban planning, and architectural and urban design come together in this framework to look at the possibility of offering healthy places that reinforce health-promoting behaviors, understanding health-promoting behaviors from the public health point of view, and trying to establish networks for active transportation, for walking and biking, to visit those healthy destinations. So basically what we're talking is about transdisciplinary work, trying to reach a concept with urban planners, with public health researchers, and us designers to come to common concepts that could wrap these healthy destinations together in a network that is accessible for all vulnerable groups and different populations. Well, I really wanted to make this a little bit more interactive. I was not really prepared for this kind of a scenario. I was wondering if there was any questions to this point. This has been a really quick overview of the first block, which is dealing a little bit with the concepts or what we have theoretically in these three fields and how we look at walkability or the opportunity of designing more walkable neighborhoods from each perspective. So I'm bringing this up because from at least the public health point of view, there is a sense of how to promote healthy behaviors, which is not really linked to the way that we design built environments. There's a very abstract feeling for what the built environment is. And on the other hand, we have designers and developers which are dealing with the built environment in their work on a daily basis, and sometimes the design solutions or the built environments that are rendered in our cities are not linked to health behaviors that could actually have a better outcome in our health. So that is the whole purpose of the framework, to set the table for different disciplines to work together in a transdisciplinary way instead of developing concepts from their own perspectives in a multidisciplinary way or interdisciplinary way. So that's what the first purpose of the framework is to break down the language so we can all have design tools and discuss and see how we can do city development in a comprehensive way. Excuse me. So in Block B, I'm going to present basically the research objectives. How is it that these good intentions can be achieved, how to ensure healthy destinations at neighborhood scale, how to ensure a pedestrian network for all population groups and mobility requirements for those vulnerable groups. So that is a graphic breakdown of data points which are looked at from the public health perspective and the other two disciplines. And what it looks at is basically looking at subsets of populations in a neighborhood, basically. That would be kind of like the scenario, the scale, an urban setting as a neighborhood in scale. And basically it tries to attain three main objectives. In public health is to describe the population and the health status of the population. It's really important for us as developers, designers of the built environment to know who are we designing for and what are the trends in that population in terms of health status. Is that population, does it have a trend of obesity and overweight and all the different diseases which are linked to overweight and obesity? Or is that an aging population like most cities we have in Europe? So we have to know better about the population that we're designing for. From the urban planning perspective, to look at how the city is the formalities of the city in order to achieve shorter distances to different services. We'll look into that in detail further on. And from the designer's point of view, to look at what qualities at the street level can actually invite or encourage that population to have access and to these different services which reinforce our healthy, health-promoting behaviors. For example, as I pointed out there, you might have at the macro scale a number of bus stops, for example, which are good indicators for a walking community. If you have good public transportation services, as for sure you have here in Sweden, these are focal points for people to walk from home to a station and to commute and to travel to work. But one thing is having a certain amount of these stations, but the other thing is looking at the qualities in the path to reach that station, that bus stop, and the quality of the stay at the bus stop. So that's how it breaks down. So these are like overall aspects of what we look at when we're describing the population from the public health perspective. Basic demographics, health status of the population, and environment determinants for these three healthy behaviors, or let's say protective factors or determinants for health. And from the urban planning perspective, basically what the first approach is to look at how is the formality of that neighborhood in this case, or how does it look like in its macro-informed factors. And for that, the literature in walkability supports the idea of the 3Ds. Maybe you've crossed across this literature from Robert Cervero. It's really well known about density, diversity, and design. And it supports the idea that the more density we have in our cities, the shorter distances we have, and the better opportunities we have to go from point A to B in our cities. So, for example, we have density of crossings. As you can see, we have, these two images to the right here are grids from Los Angeles in the United States. And the first one over here is Venice. So we see that we have these three areas which are the same, but with different amounts of crossings per square kilometers. So, my guess would be that one, like in the far left, would be more walkable than the one in the far right, and for obvious reasons. You have better chances of finding different uses, and you have a different feeling for decision and path decisions in one scenario than in the other one. So that's one of the first things that we look at when we evaluate these environments. The other one is density of uses, and these are two scenes in Berlin, not so far one from the other. One is in Hageschemack, those that know Berlin, that's in Mitte, downtown, and we have a variety of uses in the ground floor, one very next to another. There's a huge density of uses. The other one is Hellersdorf Sur, which is basically composed of structures for living, housing, and very monotonous. And basically, there's nothing to do, well, there is a small core to this neighborhood where you have certainly some services, but the first option would be to take your car and go to these services, which also have other indicators like parking lots and so on, which indicate that it is a very highly car-dependent neighborhood. And the third is density of buildings. Well, the more dense we have, certainly the more density of buildings we have, it correlates with also possibilities of having more uses, and also the possibility of having more people that are living in these buildings. The more people, the more opportunity of walking around the neighborhood, more walking rates. So the second would be diversity. We also look at, after looking at the density of the city, or the different types of densities we have, we also look at the streets and the composition of the streets. This is really important because then we have a feeling if the city has been planned or the neighborhood is planned for a certain car dependency, or it takes in consideration active transportation as an alternative for travel. So this is, I think this is in Canada, in Ottawa, where it's balanced out, 50% for active transportation means, and the other 50% for motorized means of transportation. It's pretty even. And the third, design, deals basically with three different layouts that we have in urban sites. One is the building layout. The building layout can tell us a lot if we have a walkable neighborhood or not. We can have a very monotonous, long buildings, 400 meters long, as we have in post-war housings in Berlin, for example, or we can have possibilities of buildings that could offer interconnections or bridges and so on that could easily leave path-throughs and so on. The second would be the green layout. The green layout also gives us, at the macro scale, a lot of information. If there's the green is composed through alleys or along streets, well, most of the time it supports the pedestrian. It gives the pedestrian scale, and it is supporting the pedestrian environment. Whilst when we have huge extensions of green, which sometimes are not programmed and so on, it doesn't support pedestrians that much. And the third layout is the street layout itself, which sometimes that street layout offers connectivity for pedestrians and bikers, and sometimes it just doesn't. Like sidewalks that suddenly disappear. Suddenly there's disruptions in the biking lanes that all of a sudden merge into lanes for cars and so on. So these are the three layouts that we look at when we look at design. For the architectural and urban design assessment, what we look at is at the micro scale. And there's 4 conditions for pedestrians and for bikers, for active transportation, that have to be present at the micro scale. When we look at neighborhoods, when we look at sidewalks, pedestrian paths, we have to be aware that these 4 conditions have to meet. In walkability, it's a standard almost that we ensure safety. Safety is the first thing that pops up that has to be in our checklist. We look if we have all those safety let's say, features in line. Then we look if there's a path usage. The path use is basically the purpose of the walk. If we have services which we actually need to in this pedestrian network. If the users are there, if there's driving focal points, attractive points, comfort, features for comfort, and certainly some aesthetics to the network. So basically this is very quickly an overview of how we assess the data at the macro and the micro scale. And for the macro scale, it's very straightforward. What we use is a lot of databases which are available, and at least in Berlin, there's a lot of databases which are actualized, they're free of use, published by the development entity, which is the Senat, and it's called FizzBroker. So there's a lot of layers of information that could actually describe what the macro urban form is at that neighborhood or at the city scale. And for the qualities, it's more of primary research or field research with, well, we make photography surveys, we do a checklist, and we go out there and we look at these different qualities and to see if these four conditions are accomplished or not. This is kind of like, well, this is a checklist actually that was composed for the fieldwork that was adjusted for the fieldwork of 2 neighborhoods in Berlin to do the fieldwork actually. And well, the second part of Block B is I wanted to show you like some of the assessments that were done with students, and actually the kind of data that was collected for these 2 neighborhoods that we assessed throughout 2 semesters. Well, as I said, this was basically the work of 2 semesters, and which illustrates how the framework collects information to evaluate up to what degree these neighborhoods are walkable friendly or not. And the first part is going through density, diversity, design, 3 macro factors I was talking about. And the second part is going through the 4 conditions for walking. Well, the first thing we do is basically we develop a model, which a model by itself, and especially for the scale, doesn't really say much. What it does is it illustrates a little bit like the heights of the buildings and so on, void, and we've all done models, and they're more like good looking than really offering information. But for walkability, what makes a difference is that we, as you can see, well, there's a black spot over there. Well, these are transparent printouts with measurements, which are actually looking at the diversity of the street and explaining us in scale what amount of surface is dedicated for non-motorized transportation modes and motorized ones. So what we write there in these different transparencies are percentages, and to have a feeling of the scale, right, of the amount of surface that we have for one mode or the other in comparison to the neighborhood. Well, this is all like gathering of information, dealing with the density of uses. Where are the densities mapped? Where are these uses mapped? I'm sorry. And the idea of this is to map the uses within the 3 realms that we were talking about, of these health-promoting behaviors, or these, let's say, protective factors, which deal with the food environment, the social environment for social encounter, and the active environment for physical activity. So these are different outlets which are categorized within these potential health-promoting drivers. Oh, let's mess up there. looking at bus stops and so on. And these are just like layers of data trying to recreate what the macro-urban form factors of the neighborhood look like. The layer of buildings and, wait a second, this is right. Greenery and the street layout, which we saw already. Then we made a micro analysis to look at those four conditions for pedestrian activity in a very singular street, which is the Schillingstraße in this neighborhood. This is a neighborhood well, basically it's a post-war housing neighborhood with a lot of unprogrammed surfaces, a lot of parking lots and greenery, which don't really have functions. And so this street had the potential of bridging two very important stations. And what was we were looking at it as having the potential to bring all those qualities which are not present, and make an intervention there, and as a pilot for the rest of the neighborhood. So this specific street was very important for us to evaluate and to see where the potential was. So we were looking at purpose, the different uses in that street, safeness aspects, like ramps, sight line as well, quality of pavement, different qualities of light for day and nighttime, buzzers and so on. As I said before, safeness is basically one of the aspects in walkability which is better assessed and has more literature to back up that as we improve safeness, basically, it correlates with higher walking rates. But alone, it actually doesn't do anything if we don't consider the other three conditions, like, for example, comfort. Is the pavement comfortable for walking, skating, or other activities, biking? And we end up with the aesthetics, the imaginability of the place. Does it have an image? Does it respond to a certain aesthetic quality? In this case, our street has some relevant buildings that we could say are focal points where people would visit. There's a cinema at the end of the street where the U is over there. There's like the two stations, which definitely has some image, brings some image to this quite depressed neighborhood. And in these qualities for aesthetics, there's basically 5 different features that are that we could say could be quantifiable: imaginability, enclosure, human scale, transparency, and complexity. As you can read, well, maybe you can't read it, but it's that's what we look at in order to express if there is certainly aesthetic value in the neighborhood. And lastly, I would like to show you a network plan, if it opens. Okay. After much analysis and spending a lot of time doing field work and so on, well, basically it was proposing how to improve connections to stations and to different outlets in the neighborhood, and proposed uses as well. And basically the assessment came from formalizing as well informal paths, reutilizing certain surfaces. There were like photographic surveys done in winter to look at informal paths along the snow, and summer as well, where you would have definitely some paths done in the greenery and so, shortcuts. So here is what the students tried to accomplish was not only to formalize what is very clear, that there's a travel purpose, but also there's trials or paths for leisure, recreation, and also for physical fitness, and for other uses than travel. Well, basically the design part of the course was very, very short. It was only a couple of weeks, so students were very much orientated towards doing the research by itself, assessing information, looking at sets of data that would support the idea of why the built environment is not accomplishing or is not backing up these health promoting behaviors, as in this case it's walking specifically. So they only had a couple of weeks to come up with some ideas of how to improve these paths and where exactly to develop them. So there are only like sketches responding to these needs. Well, and this basically is a proposal which responds to the different problems that were assessed at the micro scale. Problems. Okay. As for example, pedestrianizing very broad avenues with 6 lanes, and how to solve that. Different modes of transportation in one single area. So, well, the research basically finishes up by wrapping up of facts about these neighborhoods from the public health perspective. What are the problems found in one specific neighborhood, which was Marzahn-Hellersdorf? We found something really interesting, that was that the life expectancy was 2 years under the rest of the average for Berlin. So this talks a lot about the inequity or inequality, I would say, that we have in the health status of our different districts. So there is definitely some differences there. We found that in this neighborhood we have the highest obesity and overweight rates. We have more children watching TV. There's a lot of surveys in that direction that we found out that. As indicators, like large parking lots close to stations, to S-Bahns or to train stations, whilst in other neighborhoods of Berlin, what we have is parking places for bicycles. So these are indicators which are telling us a little bit of what the behavior of the population is there. And from the public health perspective, there's a lot of things that tells us what how healthy this population might be. But also, from the built environment perspective, we also assess a lot of data that could explain how the different behaviors of that population is making them healthier or unhealthier. So basically, by assessing the built environment, we're completing that equation. We're explaining a lot through assessing the built environment, a lot of what are the different activities and behaviors of that population which could make them healthier or unhealthier. Well, and I would like to wrap up everything with this slide, and basically it gathers what this input I brought you today, that it's about developing healthy places, healthy spaces, and having a supportive network, active transportation network, which attends the needs and necessities of the population in its whole range. And for basically vulnerable groups, attends the whole the whole population itself. So I would really like to welcome some questions or any remarks that you would have. Thank you very much.